Great. All right, I think we'll get started now. I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski. I'm the host for the Vasculitis Foundation Educational Webinar Series, but I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we'd like to thank our sponsor, Novartis, for supporting these webinars. Today's webinar is What You Need to Know About Relapse with ANCA-Associated Vasculitis with Dr. Junek. And after we finish this webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who registered today will receive an email link to it as soon as it becomes available. I'd like to introduce our guest for today. Dr. Junek is a Canadian-Australian rheumatologist and clinical scholar at McMaster University who's completing his PhD in health research methods. He completed his internal medicine and rheumatology training at McMaster, as well as a 2-year subspecialty fellowship in vasculitis as the Vasculitis Clinical Research Consortium and Vasculitis Foundation Vasculitis Fellow. Well, that was a mouthful, but welcome, Dr. Junek. We're so happy to have you here with us today.
Thank you for having me, and it's a pleasure to be here and to chat with all of you guys today. If it's all right by you, I'll take over the screen sharing.
Actually, I think before we get started, we have a poll for the audience to
Yes.
tell us a few things about themselves. So if that's okay, I'll go ahead and share that now. If everybody will, you should be able to see on your screen a couple of questions. Let's see, I think we have 3 today. Yes, 3 questions. If you want to go ahead and answer those whenever you can. The first one is, have you ever experienced a relapse of vasculitis? And the second one is, what was your first symptom of relapse? And you can choose one answer for that. And then the third one is, what are the biggest challenges you've faced in preventing relapse? I'll be really interested to see these questions as a patient myself who's had relapse and remission.
That's usually the best saturation you're going to get, but
80,
more than that's a good outcome.
85 was great. Okay, we're going to go ahead and end the poll now and share the results so that Dr. Junek can see and so that you all can see the answers here. I hope you can see those answers now. And Dr. Junek, if you want to comment on what you think of some of the answers, that'd be great.
Yeah, most of these, so we're looking at about 31% of people having had a relapse, 20 with maybe and 50 without, and that about lines up with what we would expect across the average patient population with ANCA vasculitis. We see most of the symptoms. I'll talk actually about the symptoms associated with relapse a little bit more when I discuss that in my lecture, but that seems to line up to a certain extent with what we're looking with what we have seen in the literature. And interestingly, and in terms of the biggest challenges we have had, we're doing a lot of research looking at finding ways to better involve people with vasculitis in care, and the coping with anxiety and distress and lack of information is a theme we've actually seen as a huge component, and I'll actually be talking about that a little bit later in the presentation as well. So it looks like you guys are in the right place for me to hopefully at least answer some of these questions, if not address where we are within the research community around them.
Okay, well, thank you so much for sharing that with us, everybody. It's great to take a temperature of who we have in here. And Dr. Junek, whenever you're ready, you can share your screen. And if you wouldn't mind, let us know if you have any disclosures today as you get started.
Yes, and I have my disclosure slide up to
Great.
the coming in. All right, so hello again, everybody. So we're going to be talking, as Kathy said, about understanding relapse and ANCA-associated vasculitis. And as she said, and I just like to reinforce, I can't provide you with individual medical advice. None of the things that I talk about today should you pursue on your own. If you want to think and consider changing or discussing your care further, I would do so with your doctors or treating team. Some of this research has not actually been published yet or is disseminated within the wider community, so you are some of the first people with ANCA vasculitis to see it, and so your doctors may not even know about it yet. And some of these findings may differ from current guideline recommendations in ANCA-associated vasculitis. So some of these are very much in the forefront on what we are thinking about with relapse, so you can get an idea of both where we are and where we are going. In terms of disclosures of interest, these are mine. I received some additional funding for my fellowship from Roche, and then I've done some consultation and advisory board work with several other companies who manufacture drugs for vasculitis. So as we all know, ANCA-Vasculitis, why we're all here, our favorite disease or least favorite, depending on how you want to spin it, with our anti-neutrophil cytoplasmic antibodies can affect virtually every part of the body and most frequently affects the kidneys, nerves, skin, lungs, and sinuses because that's where all the small blood vessels are. And ANCA-associated vasculitis is a small vessel vasculitis. One of the most interesting things about ANCA-Vasculitis is that it can affect any part of the body, but one of the hardest things that makes it so hard to study is that it can affect any part of the body. So being able to measure and label a quantity of how much vasculitis is going on and how much it is impacting somebody is actually quite different. It is quite difficult. And so we have only really in the more recent years come up with both effective medicines and effective ways of measuring and actually capturing ANCA-associated vasculitis. And relapse is actually one of the more important ones to consider this with, because assessing disease and other aspects of ANCA-vasculitis and disease activity is quite tricky to determine if somebody's in relapse. So as a reminder around our basic treatment for ANCA-vasculitis is when somebody has a diagnosis of vasculitis or new recurrent disease, we typically treat them with some sort of induction medicine, which is typically fast-acting steroids, and now we have avacopan. Sometimes people with bad kidney disease, we do plasma exchange in them. And we typically do this with a co-induction agent, which in people with severe disease is most frequently cyclophosphamide or rituximab, sometimes both, and sometimes for less severe disease, we use mycophenolate, methotrexate, and other medicines. We then provide them with ongoing maintenance therapy in order to both keep the disease in remission as well as to prevent relapse. And what we do for maintenance therapy, I will be talking about a little bit further from a treatment perspective. So remission, and I understand you had a remission talk earlier, so this isn't a deep dive on remission. I know there's many other parts, is what we are defining here as a state of when you have no evidence of active vasculitis based on signs, symptoms, or test imaging, and this can be on or off treatments. There are some people in remission. Most people are on treatment and still in remission. This is important to differentiate in terms of relapse from damage from your vasculitis, which is not active disease, because damage reflects irreversible changes to tissue that have occurred from vasculitis. So common situations for this is if you have like ongoing crusting, ongoing nosebleeds, or discharge, where you have changes in your sinuses from your vasculitis. Those may not heal up, but can be controlled with medications and therapy, and that's not necessarily considered active disease. Ongoing weakness or numbness if you sustain nerve damage from something like mononeuritis multiplex or stroke, or shortness of breath or cough with if you have lung nodules or pulmonary fibrosis. Because these symptoms can be ongoing and waxing and waning, it can be very difficult to differentiate active disease, that is new inflammation driving these symptoms, from old damage. And determining if somebody has relapse is actually it can be quite difficult because we need to do extensive testing around that time. And we often have people who have grumbling symptoms where we have to do a bundle of tests before we decide they're in relapse. So when somebody actually has relapse, we define this as a new symptom or testing or imaging, such as decreased kidney function, indicating active ANCA-associated vasculitis. And typically in research and in real life, we often pair this as requiring a change in treatment. And so sometimes you can have some symptoms such as increased fatigue, increased joint pain, where it can be more difficult to tell if you're having a relapse at any given time. And sometimes at that point, we give people a trial of therapy to see if they are feeling better or not. And sometimes they do, and we do think this is a relapse, and sometimes not. So this pairing with a change in treatment is important to consider. The other thing that makes relapse difficult to separate out is that both relapses in ANCA-vasculitis are common and not relapses in ANCA-vasculitis are common. Because ANCA-associated vasculitis leads to tissue damage, you can get infection from the tissue, often the lungs and sinuses, be more vulnerable to having bacteria or viruses land on them. We're also on immunosuppressive therapies, which decreases our immune system's ability to fight off infection. We can sometimes mistake day-to-day fluctuations in, say, sinuses, like changes in weather, as being a relapse. And you can also get blood clots, which we know you are more vulnerable to in ANCA-vasculitis. And both from the disease and more so from the treatment, we can be at higher risk of sustaining malignancy, which can sometimes look like relapse as well. So it is important to separate out relapse, but it doesn't change the fact that they're common. And this is data from the PEXIVAS trial, which was the largest prospective randomized trial done in ANCA vasculitis, published in 2020 in the New England Journal of Medicine by Michael Walsh, who's my PhD supervisor. And within that trial, we saw that after achieving remission, about 11% of people relapsed within 1 year, 25% by 3 years, and about 37% by about 5 years. Now, I'm going to talk about this a little bit differently, but depending on your flavor of vasculitis, GPA, PR3 positive disease, up to 50% actually relapsed at 5 years, or it was about 25% with MPO. So we do know that not everybody is at the same risk of relapse, and we're going to be talking about that more later. Now, we often get multiple questions around relapse, and so I wanted to give some highlights around what are some common thing around what goes through our head in terms of identifying relapse, as well as talking about some common questions that we get around relapse and how, as a patient, to think about them. So first of all, so some classic examples of relapse are people with facial or ear pain, worsening sinus discharge, or hearing loss, which is common in granulomatosis with polyangiitis. And on the surface, this may seem similar to initial symptoms, but this could very easily just be a sinus infection. This can be age-related hearing loss. This can be allergies. And so in order to confirm a relapse, we often need things like a CT to demonstrate there have been new bony changes on the sinuses or new inflammation. And we may need an ear, nose, and throat doctor to go in to confirm there's inflammation there, and actually also to culture to see if they're negative. And sometimes we have both flares and infection where we have to treat with both antibiotics and immunosuppressants at the same time. Another common example might be an increase in creatinine or blood or protein in the urine with somebody with MPA, microscopic polyangiitis, which frequently affects the kidneys. And this is often considered a classic sign of relapse. However, this can just as easily similarly be a UTI, and it can actually be kidney stones. I saw somebody in clinic today where there was concerns for a flare of their disease, but it actually turned out it was all just their kidney stones, and they didn't need any changes in treatment. They just needed somebody to break up their kidney stones. Finally, cough, which is a common presentation, bringing up a little bit of non-bloody sputum or phlegm in somebody with eosinophilic granulomatosis with polyangiitis, which can have a whole bundle of different pulmonary manifestations. It can be very tricky to tease out an asthma flare, eosinophilic pneumonia, infectious pneumonia, a lung clot, and other causes of issues such as cardiac problems. So we often need a CT to show that there's some sort of lung change there. We often see it's not improving with antibiotics, and we may need a bronchoscopy to rule out infection. So just the steps of confirming that somebody has relapsed and what are considered to be common ANCA vasculitis symptoms can be frustrating for us because there's so many things we have to think about. Frustrating for you as a patient because you just want to feel better, which is entirely justified, and creates time in order to get to treatment and to confirm the diagnosis. We do know, though, that relapses tend to occur in organs that have been previously affected by ANCA vasculitis. So looking again at individuals who were in the PEXIVAS trial, we saw that about half of individuals had relapses or only in their original organs, so in their kidneys or in their lungs or in multiple organs like that. Another third of patients had their old and new organ systems affected. So they may have had their lungs, and then they now have joint problems and fevers when they have their next flare, or they now have oral ulcers or eye problems as well. And then only 1 in 6 people really had all new areas of their body affected by vasculitis. Now, this is good in that it can indicate that it's uncommon for a new symptom. And typically I tell people when you have a flare of your vasculitis, it's most likely to be in the same parts of your body that are affected, which is true. But the frustration of this is that we can also often see damage from vasculitis, as I said earlier, in these organs, and this further compounds the difficulty separating old disease damage from flare when we're coming to relapse and why we have to do such extensive investigations. In terms of thinking about some common thoughts, questions, maybe misconceptions or myths for relapse, we really don't have any clear triggers that we know of for relapse. We know that being off immunosuppressants will place you at higher risk, but stopping your drugs does not necessarily guarantee you're going to experience a relapse. It is a bit of a numbers game. We don't have any indicators to say that changes in your diet or exercise are associated with flare. So people ask me, is there anything I should be eating, shouldn't be eating, any exercise I should or I should not be doing? And we don't have any information to say it will. specific to ANCA-associated vasculitis. We do know from other autoimmune inflammatory diseases, such as rheumatoid arthritis, that people who exercise more tend to feel better and have less joint pain. And in my experience, I would say that people who do exercise and do try to move, even with their burden of vasculitis, tend to feel better with their disease. And there is probably a lower risk of heart attack and stroke associated with this. So I encourage it, but I don't necessarily think that it is going to change your chances of having a relapse. We do see sometimes that people get, say, a pneumonia or a cold or previously, especially during the pandemic, COVID, where people felt like those were triggers for it. And it is certainly possible that the immune system responding to an infection can then supersede and become more of a trigger. And these may contribute to relapse, but the data is very difficult to get. And I also wouldn't guarantee this. And I also would not necessarily say that just because you have a cold necessarily means that you should be living in fear that you're about to go into a relapse, because many people do have some degree of immunosuppression, meaning they're more vulnerable to infections. And the vast majority of people who I care for of infections don't go on to have a relapse of their vasculitis. And frankly, the main concern is just getting the infection, avoiding that from treatment. We also think that the risk of relapse does change over time, and we have long and extensive discussions about this because it's tough to get good data. We do have some small cohorts of people who have had have been in long-term remission, and we think that their chances of going down, but we don't really know. And we say maybe 5, 7, 10 years, you will have a lower chance of relapse over time. But for at least probably the first 5 years of disease, your chance of relapse in any given year remains the same. And each medicine reduces your risk of relapse, but it remains the same. So if you're at 5% chance of relapse, you're going to be at 5% chance of relapse the next year, assuming nothing else changes. So how do we treat relapse? Well, I had said on that original treatment side that on the left-hand side, we talked about flare, and we do the exact same thing that we originally do. But then once we've gotten disease controlled, there is the question about what do we do with maintenance therapy in somebody who has relapsed versus somebody who does not. And we think that somebody who has experienced relapse is probably at a slightly higher risk of infection, having a future relapse, but this is actually pretty difficult because of how we select people in research. So we have these options in maintenance therapy that we can use, and we can move between anywhere on this grid with different dosing strategies for rituximab, other drugs, not using any other agent, different dosing strategies for prednisone, avacopan, and other drugs. And all of these are potentially viable maintenance strategies. So the question comes down to, as a doctor, how do we choose which therapy? And as a patient, which therapy may be right for you in terms of minimizing your risk of relapse? So treatments to avoid relapse are a pro and con, and this balance is not necessarily balanced. It may fly in one direction for one given person based on their individual ANCA-associated vasculitis, because everybody's had a different experience of it. Somebody may have had 10 sinus infections and really not want to have any further sinus infections on therapy. Somebody may be on the precipice of having bad kidney disease and may do anything possible to avoid relapse and have a less end-stage kidney disease. Everybody's factors are different, but we do know that the pros of more treatment to prevent relapse are potentially better health-related quality of life with decreased infection, lower relapse risk, less kidney disease, and potentially less damage from disease with less immune system activity. But on cons, we do see that vaccines are less effective. There's more infection risk. You can have more side effects from drugs, and you may need additional monitoring. How do we balance this out? We need to start thinking about individual values and preferences. And this means both what you think about the medicine and your options, as well as understanding your particular disease. Now, for a long time, we had a lot of trouble controlling ANCA-associated vasculitis, since we said just give more drug to get the disease under control. And once they're under control, they should just be happy because they're under control. And that is true, because it used to be that about 80% of people with ANCA-associated vasculitis would die within 2 years of their diagnosis, and now that's well under 10%. So we're doing much better. And that has made us recognize that with different drugs, we need to find the right drug for the right individual. So coming out of the PEXIVAS trial, we saw that we had different recommendations for who should get plasma exchange, where plasma exchange does reduce your risk of end-stage kidney disease, so needing dialysis or needing a kidney transplant, but it is associated with a higher risk of infection. So we say the worse your kidneys are, the more likely you are to benefit from the plasma exchange, and thus the risk of infection is worth it. But even when we talk to people where there seems to be a fairly clear sort of medical evidence consensus about what to do with plasma exchange, when we actually survey people with ANCA vasculitis, and some of you may have participated in this survey, we found that 30% of people would just get the plasma exchange no matter what, even if there's only a little bit of kidney damage. And about 1 in 6 people would not get plasma exchange no matter what, just because of the invasiveness and the risks. And this says that even for something that's actually a relatively acute medical problem, we need to have conversations with people to understand, because everybody's experience with their disease and experience with therapy will change. And this is now being better understood to be reflected in terms of risk of relapse, in terms of actually quantifying. So we can see here, and this is research that is likely to be forthcoming, will be presented at the American College of Rheumatology in a few weeks now, a little bit less than 2 weeks, actually. We are now able to separate people's risk of ongoing relapse into sort of low versus high risk, where people who are low risk have probably about a 2 to 3% chance of relapse in a given year, whereas people who are at high risk are at as high as a 15% chance of relapse in any given year. And if you've got a 2% chance of something bad happening versus a 15% chance of something bad happening in any given year, you're going to think about how you want to treat your disease differently. And we are simply similarly building tools that physicians can use to estimate this and talk about different drug effects, both to help physicians guide their treatment and also have better conversations with people about their risk of relapse and what each drug will do. The other problem with relapse is, even though these tools measure overlying things, and one thing that came up is that a lot of people talk about fatigue and non-specific symptoms, we do know that just looking at these numbers is only gives us limited information, and we know that there are people who have some ongoing issues, and so our prediction tools are not perfect. There are going to be people who are predicted to be at very high risk of relapse who never do, and people who are predicted who are going to be just fine but have ongoing problems. And so these tools are going to be our best guess. They're a pretty educated guess, but they're still just our best guess as to what to do. And there has to be a certain amount of discussion of both a doctor as well as the people living with ANCA vasculitis to have this conversation and say, hey, what is something that is the level of risk in terms of relapse that we can both live with? And we are conducting active research into certain biomarkers to be able to better measure these, to hopefully build better tools to predict relapse in the future. The other thing that we can do now is we can start to measure risk of infection, and we have different predictors for infection that are going to be coming up soon. The last thing I would say in terms of prediction is that EGPA is the exception to these three, because as people with EGPA often know, there's much more than just the vasculitis. There's disease. There's the eosinophils filling their lungs. There's the eosinophils in their heart. It can sometimes affect their gut, and they often have bad allergy, sinus, and asthma concerns. And these are treated quite differently with IL-5 inhibition and treatment of asthma. And are not necessarily, and those are disease patterns that do not necessarily follow these rules, as flares and relapses of those are frequent and often not as severe, but often quite frustrating and quite impactful on people's quality of life. Whereas the actual vasculitis component in EGPA, which is when it affects the kidneys, nerves, maybe the heart and the skin in some people, those can sort of follow these rules. So these patterns apply to pretty much all of microscopic polyangiitis and granulomatosis with polyangiitis and a bit of EGPA. Okay, so in thinking about relapse, we have evidence from our drug trials to say what each drug can do. And we also now have the ability to talk about how we can measure what your given risks are with infection and provide people with meaningful numbers around their risk of good things happening, so avoiding a relapse, and risk of bad things like infections or side effects in terms of looking at people's future risk of relapse. The other thing that's really important to look at in relapse is people's disease experience with ANCA-associated vasculitis and how we can better both understand what this burden is and understand how that may impact how they think about how they receive ongoing care for their ANCA vasculitis. And this is their values, preferences, and individual needs, and we need to have a better understanding of this. So what we have also done is we have completed a systematic review looking at all previous research that has assessed individual values and preferences around ANCA vasculitis. And interestingly, a straw poll done in about a minute was able to highlight many of the same issues that we had. I spent about a year and a half digging through thousands of papers just to find. So it's amazing what you can do by just talking to people instead of looking through some papers. Anyways, and we have found that people who live with ANCA vasculitis, especially in terms of the burden of disease and their concerns about relapse, the things that are important to them are finding effective strategies to self-manage for their ANCA-associated vasculitis. So these are things like being able to find strategies to count on for yourself, like fatigue management, having friends who understand the disease, and having social and psychological supports from other people who have it, who can actually get what you're talking about. Often it can feel very isolating for people with rare diseases to talk to other people with to not have other people, because you can't just sit around the dinner table and talk about having your vasculitis as much as people have a social concept of what living with something like cancer or having a heart attack can. The other part of living with ANCA-associated vasculitis is feeling like you have a dedicated care team, and we are increasingly recognizing that just having this clinic, having collaborative, has close contact can be very useful. And just talking with Kathy, that she says she faithfully attends to her to getting help. And I think that having that relationship where you know that somebody is there on the other end and wants to see you regularly, who understands your disease, is quite important. And we also see this in terms of providing care for patients. The second one theme that we came into out of three was that people often feel that not having enough information is really difficult. We often say they have ANCA-associated vasculitis, and then we leave it up to them to look in AI or Google or what have you to get information. And it's difficult to be able to contextualize their information towards their disease. It's difficult to know where their disease is going, and it's difficult to know what each treatment is, how to compare them and to weigh them up, which is one of the reasons that we need better tools, and we are working on better tools to talk with people about their chances of relapse and how each medicine may help. We also know that doctors and patients may have different priorities in terms of managing their vasculitis, and that doctors may just want to get their medicines in a row and feel like everything is under control. But people with living with vasculitis may say, hey, fatigue is a real issue for me, and I don't feel like this is being addressed or managed. Yes, I'm not dying from bleeding in my lungs, but this fatigue is really important on my quality of life. And that is certainly something that we are needing to figure out better strategies to do, and there is some research on. The other thing that we saw is that having effective information to communicate around relapse requires both written, communicated in multiple methods, and we need to have more accessible information for people so that they can both understand their disease. It may be a better way for them to learn, and for them to be able to access and understand and participate in their own decision-making process. The third thing we found in our review looking at people's experiences with ANCA-associated vasculitis is that people do talk a lot about the various aspects, the benefits of treatment and the harms of treatment, but most of these are in the context of steroids. We actually really don't have a lot of information in terms of other drugs, in terms of how do we cyclophosphamide, rituximab, azathioprine, what are people's lived experiences with these? We also don't have a lot of understanding of how people's experience with being treated for relapse may impact them and motivate their decision making, and saying, yes, I got better, but needing to be retreated or having recurrent disease really changed how I felt about my disease and changed my thinking. So even though we have some understanding of the many aspects of how people's disease impact them, and there's also several studies that highlight how living with nerve damage, living with recurrent skin disease, all of these things have a huge impact on health-related quality of life. How we treat and how we deal with the treatments around this disease is something we need to better understand, because having periods of active disease are hopefully short, but having periods of being on treatment can be long, and managing the side effects of treatment and how to potentially afford, access, follow, continue to deal with the side effects is something that we deal with quite a bit, and that chronic disease burden can be quite a concern. So coming out of all of this, we have seen three really important points: that having somebody who you can talk to about your disease is a critical source of support in navigating a diagnosis of ANCA-associated vasculitis, be it with friends, be it with colleagues, be it with family, be it with your physicians. We know that uncertainty is an important stressor in addition to the medical the consequences of living with ANCA-associated vasculitis, and part of this is inherent in the disease, but may also be improved with better communication. And we also know that treatment is a central part of the disease experience of living with ANCA vasculitis, and there's limited experience. So where we are going from here with this around not just understanding relapse, but what we can do with it, is we're actually going to be surveying individuals with ANCA vasculitis about their experience with treatment. We're looking at developing a decision aid where we can present all this information and say, hey, not only now do you have this disease, it's now in remission, here's what your remission looks like, and here are the next things we need to do. What would you like to do? We would like to see how much of a difference that makes and build better models of predicting what to do for people in ANCA-associated vasculitis. And finally, there's a lot of research around better drugs to treat AAV, and those are important and coming on. But I think in addition to thinking about with drugs and getting disease under control, we really need to be better exploring how to meet people where they are in their disease. And ultimately, I think understanding each individual story of ANCA-associated vasculitis, their disease burden, and how relapse has affected them is actually one of the biggest areas, one of the challenges that we face. So hopefully out of all this, there are a couple of things that hopefully you can take away. So number one, that relapse can be difficult to identify, but they are often in areas where the ANCA-associated vasculitis was previously found, but they can take time. We know this is a source of frustration. That relapses are common and we have good treatments, but there are also other things that can go on, and managing all of this can be a bit of a complex balancing act that we need to learn how to better engage you guys in being able to do so that you feel you're a part of your own process and are able to take better ownership. Three, that everybody's ANCA-associated vasculitis is their own. And this is one of the tricky parts, that, as I said at the beginning, that every different part of the body can be affected. And so building tools that can be accessible and useful to everyone is challenging, because having a heart attack is very straightforward. They have one problem. There are some varieties in heart attacks, but heart attacks are heart attacks. ANCA-associated vasculitis has a lot of variety. So finding ways to communicate with everybody in a meaningful fashion across the entire spectrum of disease is challenging, but an important thing to address. And ultimately, we need to learn how to meet people's needs better and look at individualized treatment to be able to target relapse in the future, to both minimize their disease and maximize their ability to avoid side effects from therapy. So it's hard to go through everything for relapse in a 20 to 25-minute talk, but hopefully this was a good overview for you around people's experiences with relapse, as well as where we are with research and what we can do with treatment. And I look forward to any and all questions.
Well, great. Thank you so much. I, of course, personally found most of that fascinating and very helpful. If you want to go ahead and stop share, then we can move to the questions. I have gotten a few that have come in. Actually, I've gotten a few by email of people who couldn't make it in the meeting, and
Sure.
also a few that are in here. So I'm going to go through a few with you. The first one is, how do treatment strategies differ between managing a relapse and managing the initial onset of vasculitis?
So that's a good question. So it everybody, I can default to say that everybody's vasculitis is their own, but I will say that often if somebody has a treatment with vasculitis that works to get the disease under control, that treatment will typically work again. When maintenance, so for example, when we use rituximab as a medicine to induce remission, we use 4 times the dose of rituximab, 2 grams at the beginning to induce control, whereas we typically use 500 milligrams every 6 months to maintain control of the disease. So it might just be that if somebody relapses while they're on maintenance therapy, that they're just not getting enough drug and they just need more drug. And there are some people who just need more rituximab. So we do find that many people, when we use an initial medicine, we get them under good control, and sometimes we just go back to the old medicine that worked, and then we change up strategies for maintenance therapies. And this is why I brought up that grid of different maintenance options that can work, because depending on how somebody is doing over time, we may be able to de-escalate their therapy if we think they're at low risk of relapse or having side effects. Or if somebody has a relapse, as we may just keep adding on more and more drugs. And there are some people who I care for who have very difficult to control AAV, who need up to actually 5 different medicines to keep their disease under control because they keep relapsing. And so it's quite variable, but in terms of initial control and management, if something has worked before, you keep doing it because typically it tends to work again. But if somebody, say, 3 months in has just started treatment for a flare and we think they're flaring again, not sure if their initial disease is controlled, we'll probably change up strategies, because we will say, yep, we gave them all these medicines, but this is clearly not enough and we need to either escalate or change what we're doing.
Okay, thank you for that. And I just did want to say that, as I said earlier, that I'm a patient living with MPA vasculitis, and I've been asked by our producer in the background to mention that about myself. We did have a short talk, Dr. Junek and I, at the beginning, and I was diagnosed in 2008. I had treatment from 2008 to 2013, on and off again, relapse, remission. And then I was 9 years in remission off treatment. So I just want people to know because sometimes I know that's one of the most frustrating things is knowing when relapse is going to happen, how long is it going to last? It's different for everybody. But as Dr. Junek said, I have been seeing my doctor every 3 months since 2008. I think I know everything about him and he knows everything about me. And I had a relapse 2023 and 2025. I've been in remission about 2 months. And I have very I put my trust in my doctor, and he looks at all the labs and everything in addition to how I feel. Sometimes he said yesterday to his fellow that it sometimes doesn't make sense. It's what the patient says that leads you in the direction of the right thing to do. So I shared my little spot, and now on to questions. The next question is, can the COVID or shingles vax be possible triggers for relapse? I know that's a very common question.
Yeah, so we so there is an area where it is tough to know. So the overall so I think there's three things to tease apart. Number one, benefit. Number two, harms. Number three, can it be causative? So number one, the consequences of uncontrolled COVID infection, especially in people on rituximab and shingles, can be devastating in people with ANCA-associated vasculitis. I have seen this many times, and whatever I may say about their potential risks, they are absolutely outweighed by the benefits of these vaccines, and I would continue to regularly endorse them because I have known people who I have cared for people who have died from both of these things who have ANCA-associated vasculitis. Any vaccine does trigger an immune response. That's the point of a vaccine, to trigger the immune system to create antibodies to fight off whatever is the specific exposure contained within the vaccine. And so that immune system activation, I do get anecdotes of people who have potentially had some flares a couple of weeks after. I wonder if that was the vaccine. And in somebody who is a vaccine is not the world's biggest immune insult. It activates the immune system, but it's not a huge stressor. So for those people, I sometimes wonder if their flare was just going to happen no matter what, and the vaccine was just the thing to bring it out, or if there was something special about the vaccine. And I'm still not sure. Data around the COVID vaccine and autoimmunity was the subject of focus for quite a bit of time in terms of um, both new onset giant cell arteritis specifically, as well as other autoimmune diseases, including myositis, for which there are some possible tenuous linkages there, but the most of the data does suggest that people who have the COVID vaccine, and it's just there's been a lot of people who got COVID vaccines, and we were in a modern era, so we could study it well. There seems to be most consensus that if there is a linkage between these vaccines and flares of disease, it is not a common or frequent outcome and is not something that is at all to be expected. And I often tell people it is possible that we might see a little bit more disease activity. People often feel, especially if they have rheumatoid arthritis, that their joints are a bit more achy and things like that. But and so I warn them, you may find your symptoms just feel a little bit worse if your immune system's a bit more active from the vaccine, but I have not seen a lot of flares in talking to people around that. And, some people may say a little bit more sinus discharge for a few days is a flare of their disease. We typically say that if somebody has a symptom that gets better on its own within a few days, that's probably more related to damage or just their natural day-to-day variation in their lives rather than an outright flare of disease. Because typically a flare is something that can't be controlled on its own. And that's why we often say requiring a change in treatment to be required for a definition of a relapse or a flare.
Well, thank you for sharing that with us. I know all of us, if we could know exactly what caused a relapse, we would love to know that. I think that was my main thought in 2023 after 9 years off treatment in remission. Like,
Yeah, yeah.
was it stress? Was it like there were a lot of things it could have been in me, but we don't know yet. I understand that. And I thank you for trying to answer that for us.
Our
Well,
I was just going to say that our long-term remission patients, our group there, we never stop following them. We don't see them every 3 months. We don't have the capacity to do that, unfortunately, but we always tell them that we continue to follow them because ANCA vasculitis is never something you're cured from, at least for the moment, maybe with CAR T, and so it is an ongoing thing, and I think it's important to not live in fear of relapse, but to be aware, and that's the nature of the diagnosis. I think we had somebody who went out 17 years before they relapsed as well. So,
Wow.
yeah.
That's very hopeful. All right, on to the next question. This person says, is burning pain on the back of the thigh and aching and throbbing pain on the outer thigh and sensitivity to touch, is that a flare-up, and is each flare-up cumulative?
So whether or not that's a flare-up, I would have a tough time commenting on because off the top of my head, I can think of about 5 or 6 things that could be going on there, and I'm not going to do a diagnostic challenge on that one. But if it were found that that were to be, say, muscle inflammation or nerve irritation associated with vasculitis, that could be considered a flare if somebody was on treatment and that's uncontrolled disease that improves with therapy. Most people who have symptoms like this, we typically find that there is not evidence of active vasculitis for symptoms like this. Typically, we find there's more benign causes of that, which is good because it means we don't have to increase somebody's ANCA vasculitis treatments. But and this is again what I said at the beginning, with the frustration of separating relapse from other causes. In terms of the question of whether or not relapses are cumulative or not, so in terms of like, does one relapse beget more relapses? We're really not sure on that. There is some data that says yes and some data that says no. Do relapses accumulate more damage in certain organs? That can happen. So if you have multiple relapses in nerves, you can have progressive nerve issues. If you have multiple relapses in your kidney, you can end up having progressively worsening kidney issues and end up with end-stage kidney disease. How bad you have it at the beginning does not necessarily indicate how you will end up. In the healing process, we see people continuing to improve as much as 2 years out from their diagnosis and most recent period of activity. So there is often a little bit of damage there, but we see people who have started out needing dialysis for their kidney disease or needing a ventilator from their alveolar hemorrhage who come back with completely normal lungs, completely normal kidneys after it takes time to heal. So they can be, but they are not, they don't necessarily have to be. And measuring damage in vasculitis is actually quite tricky for that reason because it's hard to quantify how much scar things like that are. And that's actually an active research challenge as well.
Well, thank you for that. And as I said to everyone, we're going to try to, I might skip over a question or two if they are very personal about your journey with vasculitis and something that Dr. Junek cannot answer because you're not his patient. But moving on to the next really good question. For GPA patients on methotrexate, how long can one be off methotrexate for surgery without triggering a relapse? Some doctors want patients for methotrexate prior and after surgery.
Yeah, it's a good question. So methotrexate and most of these drugs, they last in your system and their effect far longer than just taking them for a week. When people start on methotrexate, they need to be on them for anywhere from 6 to 12 weeks before the drug really has its effect by having its cumulative immunosuppression. We have done research in people with other autoimmune diseases and holding methotrexate for a week or two after flu vaccine to get a better response to the flu vaccine. And we know that people can get a little bit more joint aches, but most people do just fine. We also know that many surgeries, the surgeons are a little bit more apprehensive around it. And honestly, for many surgeries, you can just stay on a lot of these drugs through the surgeries, and it's the surgeon who's being apprehensive rather than the patient with the issue. So there are ACR perioperative guidelines, and sometimes being able to advocate to say, no, I can stay on my drug is good. But I would say that even if you're not taking your methotrexate for sinus surgery for a week or two, it's not that you're without immunosuppression. The methotrexate is still working. It often takes time. You may get a little bit of a worsening in your sinus symptoms, but If that's the difference between being able to get the surgery and not get the surgery, sometimes that's the decision that needs to be made. But I would not say that just because you've missed a week means that you absolutely cannot take it. As many of you know, with these medicines, you want to skip them while you're on antibiotics to give your immune system the opportunity to work. And so we say that, and so we say the same with surgery. And just because you have an infection requiring antibiotics and you skip a week doesn't mean you lose their effect. So I missing a week is unlikely to be a significant issue. And yeah.
Okay. Well, thank you so much for that. I have a variety of rituximab/relapse questions. I'm going to try and sort of put them together because I feel like you could answer them
One can write
together.
an entire encyclopedia on this one. There's a
Yes.
lot of those.
So one of them is if you normally get it rituximab every 6 months and have a flare up, is it common to do 4 months for a few times? And the next one is what's the difference between fixed and tailored rituximab dosing? And one more to add in there. Is there data that talks about the different incidence of relapse relative to the length of time on maintenance rituximab? So I know that's like, but maybe that's all rituximab questions.
So I'm going to tackle the easy. I'm going to tackle the quick and easy one first. There is no data that shows. Your risk of relapse is the same from 1 year to another. So if you're at 10% chance of relapse in any given year, year one, you've got a 10% chance, year two, you've got a 10% chance, year three, you've got a 10% chance, and so forth for however long the risk period is, which, as I said earlier, we don't know. Rituximab reduces that by somewhere between 60 and 70%, depending on who you talk to. And so if you are on rituximab, you go from having a 10% chance to about a 3% chance in that year. And the next year, you're at a 3% chance. And the next year, you're at a 3% chance. There is no change in your chance of relapse. It's just that every year, you're rolling the dice to see if you came up as one of those 3%. So we don't see any evidence that staying on rituximab, you see any changes in your risk of flare. And with our trial data, we say that as long as you're on the same consistent therapy, it's pretty much the same risk of relapse throughout. In terms of if somebody flares on rituximab, it kind of depends on the flare and why we think that they have flared. There are some people who they may have had a flare because so rituximab is a drug that causes the deaths of what's called CD20 positive B cells. So B cells are the cells that make antibodies, and ANCAs, anti-neutrophil cytoplasmic antibodies, are made by B cells. And so by stopping the B cells that make the ANCA, you stop the disease. Those are not all the B cells that make antibodies. There are mature B cells, plasma cells, that don't necessarily express CD20, and there are very young B cells called plasmablasts that also don't express CD20. So CD20 doesn't cover all B cells, and also rituximab is a really, really, really old drug. Because it was an early antibody, it's not very good at getting into certain tissues. So we wonder if, like, people who have really thick lung nodules and stuff like that, if the drug can't get in there, and there can be B cells that can hide in there. So we do, first of all, say, okay, why did their rituximab not work? And so you can measure how many B cells you have in the body. And if they had a lot of B cells hanging around with rituximab, it may not be that the rituximab was the wrong drug. You just didn't get enough of it, or you chew through your rituximab much faster. So sometimes for people like that, you can just give them a gram every 6 months instead of 500 milligrams, or you can give them every 4 months. To 500 milligrams or a gram every 4 months. How everybody handles that situation, there's a lot of inter-provider sort of practice difference, national difference, changes in terms of coverage and availability. We don't have right answers, and the right answer is the answer that I would say works for somebody in terms of the right dose. Does getting more rituximab get you better protection? I think on average, we probably don't see a huge difference. Rituximab probably 500 works the same. It's just that everybody's immune system is a little bit different. So there might actually be a group of people for whom the 500 milligrams of rituximab is just way overkill, and they need rituximab like once every 12 or 18 months. And they're totally fine because their B cells are super sensitive. And then there are the others who need more. So we have looked at addressing this through two things. There are new drugs that target B cells, which can go a bit deeper, can go a little bit wider, and there's currently trials to say, will these work? And that's a possibility. The other side, and that might help those people who have really persistent high B cells, or just not good rituximab responders. Sorry, I talk fast sometimes when I get into things. The other side are these people who may need a dose every 12 or 18 months. And this is where this tailored therapy came in. And this was pioneered by the French in about 2012 or 2014. I can never remember which of the two. And so they said, okay, well, let's measure the B cells and give people a shot of rituximab when their B cells come back and see if they do better. And they seemed to do okay, but when we got larger amounts of people, they seemed to overall have a little bit more flares. So tailored may not be quite as good for everybody. There's still some debate in the community around how you tailor and who you're giving the tailoring to say these things. Our approach at our clinic is to say that if you're going to treat somebody, you give them rituximab, you give them fixed doses, you don't ask questions, you have a good system. And then if somebody's been in remission for a long period of time, those people who've had really good response, we say, okay, maybe we can try spacing it out. Let's try tailored. Or we have people who have kidney transplants who are on other drugs, and we say, okay, let's only suppress your immune system just enough, so we'll give you tailored because you're already on other drugs, and those are probably helping. Or there are people who have had side effects from rituximab, like recurrent infections, or have really low levels of antibodies, and they need immunoglobulins to supplement their levels. And we say, okay, let's only give it to you because you demonstrably have really, really strong responses to rituximab. So I think this is, and the other thing that comes in as well is that everybody's a different risk of relapse. So if we have somebody who we would say is at lower risk of relapse, that could be somebody you could say, hey, we think you're lower, so maybe let's try less therapy. Or if we say you're at higher risk, we say, hey, your risk is higher, so let's give you more rituximab, and that might be better. And a way to separate it, who needs lots versus who needs a little rituximab. We need to do research and trials around that. That is a short answer to highlight the variety of ways in which one can think about it, but hopefully highlights for the people who have asked these questions the factors that come into our mind and how we think about it. And again, highlighting that there is no one right answer to this. It's the right answer for you and your context, and hopefully some of those thoughts sort of rang true to your experiences.
I think that was the most important message, is that there is not one right answer, and that, trust your doctor and communicate so that you get the right plan for yourself. Well, thank you for answering
Yeah.
that very complicated question for us. This is an interesting question from someone. Our immune systems weaken as we get into old age. Is there a reduced risk of flares in seniors or those over, say, 75 years old?
We have looked at this, and we have, you are right that the immune system generally becomes weaker, but the problem is the immune system generally gets more crotchety, and that older people are actually at higher risk of autoimmune diseases, including giant cell arteritis becoming more frequent with age, which is a different type of vasculitis, which I have a huge research interest in. So even though you have a weaker immune system that may be more vulnerable to infection, you don't seem to be at a much lower vulnerability to these particular kinds of autoimmune diseases. So it seems to be less about the overall strength of the immune system and the specific parts of the immune system that can drive these autoimmune diseases, and those parts still seem to frustratingly work. And when we actually looked at relapse, predicting estimates of relapse and relapse models, we saw that age was not a factor. So overall, your risk of relapse just continues over time.
Okay, thank you. And I think there's some redundant questions in here, so I'm moving to one that we haven't had, and this is, some people remain ANCA positive while in remission. Is there a difference in relapse rates between those who remain ANCA positive versus those who don't? And I have been ANCA positive forever, so I'm
Yeah.
very interested in this question as well.
Yeah, it's a really good question that the community of vasculitis researchers fight about constantly. So I think there is two parts to this answer that's important to take note of. So the first part is there is do you have a positive ANCA over time, and does your ANCA level go up, and does that predict relapse? So ANCA being positive over time suggests there are some B cells, and we have looked at relapse specifically to see if persistent ANCA positivity really matters. Bigger research has, and more modern research with more regular frequent monitoring of ANCAs suggests that if going ANCA negative does play a role in how much you're in remission, it's probably small. And I think this also highlights that if you're still producing ANCAs, that means there's a B, even if you're on rituximab, that is a B cell somewhere that can produce them. Um, it says that not all B cells are bad and not all ANCAs are necessarily problematic. So for you to have ANCA vasculitis in a flare, you do usually need the ANCAs, and then you need another trigger to end up having a relapse. So just having them may put you at a slightly higher risk. And I would say that the change in that is probably quite small, on the order of like a few percent. And we don't typically dramatically change our behavior based on ANCA positivity or not. We used to do that a lot, but as we got more data and we've seen it doesn't do it as much, we tend to do that a little bit less. The other part of this is there are people who have negative ANCAs and then they come up and they become positive. Those people who have dynamic ANCA changes, those are people who we might be seeing that as an early sign of relapse. So there are some people who monitor ANCAs regularly and say, oh, your ANCA is going up, we should give you treatment. And they did do that, and they've tested this strategy compared to B cells, but measuring ANCAs was not as sensitive, and that B cells were typically an earlier predictor of relapse, and they're not quite as good in that when you just measure ANCAs, you tend to probably overtreat some people and undertreat others, and so it's really just want to see if the B cells are the problem rather than the ANCAs. But there are some times where you're wondering about a relapse and you say somebody has like some new sort of like pneumonia looking things, you're not sure it's an infection or vasculitis or new sinus changes. And if they had a negative ANCA before and they now have a positive ANCA, that is a bit of a more of a suggester of an ANCA being associated with flare. But ANCAs can also go up with just general immune system activity. So you have to sort of, again, capture the whole picture. But it can be a weak indicator. But I think overall, our attentiveness to ANCA levels as a indicator of disease activity and severity has gone down over time because it doesn't seem to be as accurate as we wanted it to be. And now we're moving on to sort of better things like B cells and other markers. Yeah.
Okay, well, thank you so much for answering that question. I know that that is a difficult one, a difficult call for
Mm.
doctors as well. And I'm going to ask you one more question. Listen, everybody, I want you to know that Dr. Junek has been so generous with his time today. He's answered so many questions. I am going to ask him, I'm not going to make him answer us live, but I am going to ask him if he can help us in the catch some of these questions in a non-live webinar, maybe later, just he and I, where we get a few more of these questions answered and we'll add it on. But we'll get back to everybody on that. But this last question is very, very important for patients. We wrestle with this all the time. Communication between patient and doctor is critical, but we don't want to overload an already stressed medical system. So when is it appropriate to check in with your doctor on a suspected flare? And what information is important to present? I can't tell you how many times I've thought to myself, oh my gosh, is this a flare? Should I bother my doctor?
Yeah. So I uh, being somebody with ANCA, I use this metaphor. It's a little bit crude, but it kind of gets the point across. Being diagnosed with ANCA vasculitis to a certain extent is like being in a bit of a bad relationship, in that you are stuck in it. You can't get out, but you learn how to deal with it. You learn what pisses off the other person. You learn when you can ignore it. You learn when it's just making noise. But it takes time to learn how to walk around that person who you're stuck with. And so I often and I regularly encourage my patients. I say in the early days, nobody knows what's up or down, and the doctors may not know what's up or down. So we often get a lot of questions around this, and sometimes it is just noise, but sometimes it is signal, and we don't want to miss a flare. And certainly, I've had many people who didn't know what was going on, and then early in their treatment, they had a bad infection that we had to catch and treat because it was one of these symptoms or something else like that. I think my general approach to this, which reflects that, is to say early on, I don't think you're wrong for contacting to check in and sort of figure it out and communicate around it. Because the other thing is, as well, is when you have these treatments, when you have prednisone, we can have general aches or pains, which are not at all vasculitis, and getting a big dose of prednisone can make all of that feel better. And then all that comes back, and you're like, oh God, is this my vasculitis? And it's just, oh no, it's that one injury from 20 years ago that I was able to forget about, but now that I'm off prednisone, it's back causing
Yeah.
problems. Um, and so I think you learn to be in that bad relationship over time, and as it goes out, you get a better sense for it. But the only way to do is to learn, and the only way to learn is to communicate. And so I think that the doctors who treat people with vasculitis, we do this because we like it. And so I encourage you to sort of talk with your doctor and to establish what are good ways to communicate, what are the expectations, and say, hey, when I have these questions, what do I do? Do I wait for the next appointment? How can I get in touch with you if I'm concerned? Things like that. I think setting some ground rules should be good, but I do respect that the unknown is the hardest part, and often, and for many people, their physician who treats their ANCA-Associated Vasculitis is the only person they can feel like can really talk to.
Mhm.
So I think early on, I think it's totally fair for people to ask. And then I think over time, you sort of develop your sense of what your disease is, and you're like, this is just Thursday, or, something is fishy here. And I want to see what's going on. And you become your own advocate sometimes. And I've had so many people tell me that they know that's a flare, they just don't feel right. And so lo and behold, it absolutely is. Sometimes they're wrong. Sometimes it's like just an infection or something like that. Sometimes it's their concern, but I definitely listen. And I have not encountered a doctor who cares for people with vasculitis who disagrees with me and says, yep, a lot of times they can tell you and they know because they live with their disease every single day. And we just see them once every few or however many months that we do.
Right. And I will say that my doctor told me something recently, and this is after all these years when I was worried this time last year because everything was feeling bad, just like
Yeah.
everything. And he said to me, listen, don't ever worry about talking to me about this, but I just want to make you feel better. After you've
Yeah.
been in remission a while, your disease is not going to come screaming back on top of you. It's going to creep in. So
Yeah.
you have time to think about it and talk to me. And that made me feel
Yep.
much better. So I appreciate all that you said about communicating with your doctor and that you all want to hear from us because I think,
Yeah, yeah. No, like vasculitis is one of the weirdest corners of the of medicine, and the people who do vasculitis don't go there begrudgingly. It's because there is something in them that they're like, I need to do this work. So we are in it because we want to do it and because we like to do these sorts of things and we want to work with people who have complex medical diseases with a lot of needs. And that's been universal to everybody who I talk to who cares for people with vasculitis. And so I think any physician who doesn't want to hear and I don't know anybody who doesn't want to hear from somebody and would rather that person end up in a bad flare in hospital.
right. Well, thank you so much for answering all of those questions. Just before we finish up today, I want to just, review one or two more things. So I'm going to share my screen with you. I'd like to remind all of our viewers that the Vasculitis Foundation website is somewhere where you can find a lot of helpful information. For instance, just under education, you can learn more about the various forms of vasculitis. After you read about them, there's this area that says order print. You can print out this really nice document that a lot of important people have worked hard on that you can take to a primary care doctor's office. I tell everybody I just took it to my dentist so that he would know more about it because he wanted to know more about it. And also on the website, you can find a video library with all of the recorded webinars like today's webinar. On the homepage, you can find out more about patient support groups. That was something that Dr. Junek talked about as one of the aspects is having support for yourself also. And of course, upcoming events like live webinars as well as Vasculitis Foundation conferences can be found there. And speaking of new things, on the Vasculitis Foundation website, there is a new database for Find a Doctor. We were just talking about what kind of doctors will listen to you. So you want a doctor who understands vasculitis. This is a great resource for that. You can go right on here and you can, of course, you can see, you click on the Find a Vasculitis, Find a Doctor tab, and then you can see what kind of doctors you can filter for what kind of doctor you need in your location, everything to help you find the right doctor for you. And I also was speaking about upcoming events, and I just want to say there are two events that are in-person events that are coming up soon. One of them is November 1st, I think it is, in South Carolina. I will be there at that one, so if you're there, come see me. And the next one after that is November 8th in New York City. These are Vasculitis Foundation conferences and are a great way to meet other people going through what you're going through and to learn the latest information beyond what we give you in these webinars. And then finally, I just want to say thank you to Dr. Junek for all of his time that he spent with us today, and to the Vasculitis Foundation for supporting these webinars, and of course our sponsor Novartis for supporting these webinars. And the last thing is, as you all log out today, there is a survey that's going to pop up. So where the button says continue, please click continue and fill it out. It helps guide us in what webinars we go towards. We have done other remission relapse webinars, but everybody kept wanting more. So that's why we asked Dr. Junek today. So thank you so much to everybody that was here. And again, thank you, Dr. Junek, for spending your time with us and answering as many questions as we could.
It was a pleasure to chat with you, and it was glad to answer all your questions. I know that there's a lot, and hopefully we can do that recorded session later, and I hope you all have a great afternoon.
Thank you, everyone.